Thank you for introduction, Chair. Good afternoon, ladies and gentlemen. I'm Minseob Kim from Seoul National University Hospital. I'm truly honored to have the opportunity to present here. Today, I'll discuss antithrombotic medication after liver transplantation. Here is today's outline. Thrombosis after LT mainly takes two forms. First, hepatic artery thrombosis. It occurs in about 4 to 9% of recipients, usually early period. It is catastrophic, leading to necrosis, biliary complications, and graft failure. Second, portal vein thrombosis. Less common, around 2 to 3%, but still highly impactful. Risk factors include pre-existing PVT, pediatric cases, complex reconstruction, or hypercoagulable status. So even though incidence is relatively low, both HAT and PVT are devastating for the graft and patient. That is why prevention matters. HAT and PVT both have well-established risk factors. So the question is, how can we prevent post-LT thrombosis? To prevent thrombosis after LT, two strategies are essential. First, meticulous surgical technique and surveillance. Second, medical prevention, the use of antithrombotic medication. And today, I will focus on review the major medications we currently use, discuss the evidence, and show where they do or do not provide benefit. Let's start with aspirin. Mechanistically, aspirin irreversibly acetylates a serine residue in the activate site of the Bose-COX enzyme. This inhibition is permanent for the lifespan of the platelet. At low dose, the main target is platelet COX-1. This suppresses thromboxane A2 generation, which is the key molecule that drives platelet aggregation and vasoconstriction. When the vessel wall is injured, collagen and bone rebuilding factor are exposed, binding to platelet receptor. This causes platelet adhesion, activation, and aggregation. Fibrin stabilizes the platelet plug, forming a firm thrombosis. And this is exactly the pathway that aspirin blocks by inhibiting thromboxane A2 mediate platelet aggregation. So every arterial anastomosis during LT causes vessel wall injured. This is exactly why we worry about hepatic artery thrombosis and why preventive strategies are so critical. And I show several studies about aspirin and liver transplantation. This is a single-center study, including antiplatelet prophylaxis, was administered for 3 months. This patient started antiplatelet prophylaxis on postoperative day 0 to 5. Over the rate of early HAT rate is 5.5%. Independently risk factors were arterial redo, arterial reconstruction, and cryptogenic cirrhosis. Importantly, in patients with at least one of these factors, the use of antiplatelet prophylaxis reduces the rate of early HAT. This was also associated with an improvement in 1-year graft survival. In this international multicenter cohort of over 2,300 liver transplantation patients, low-dose aspirin significantly improved arterial patency. Interestingly, aspirin also reduced the risk of ACR with higher 1-year rejection-free survival. Here are two important earlier studies that evaluate aspirin for HAT. Vivarelli 2007 study, low-dose aspirin reduced chronic HAT, and Shai 2013 study, universal aspirin did not change early HAT incidence, but graft loss due to early HAT was significantly lower in the aspirin group. So then, how long should we continue aspirin for HAT prevention? According to a large national database of over 11,000 LT patients in South Korea, extending antiplatelet therapy beyond 1 year showed no additional benefit on graft survival and vascular complication or cardiovascular event. On the contrary, long-term use was associated with a significant increase in severe bleeding. So in practice, how do we actually use aspirin after liver transplantation? Aspirin should be the default in LT unless the patient has active bleeding or a very high bleeding risk. We usually start between postoperative day 1 and 3 once hemostasis is secured. The dose is low-dose aspirin, typically 75 to 100 milligrams per day. The duration is at least 3 months and often extended to 1 year based on study. RS monitor is needed, platelet count, and bleeding risk. Now, aspirin has clear benefit for arterial protection, but what about stronger anticoagulants like heparin or DOACs? Let's look at the evidence for anticoagulation after liver transplantation. Why do we even consider anticoagulation after liver transplantation? The concept comes from Berger's trial. Venous thrombosis is driven by 3 factors: venous stasis, endocellular injury, and hypercoagulability. When these occur together, fibrin-rich so-called red clot can form, especially in area of slow or static flow. In liver transplantation, all 3 components of Berger's triad are present. This framework naturally leads us to ask, should we use anticoagulant after LT to reduce this thrombotic risk? Anticoagulants act at different points in the coagulation cascade. Warfarin works upstream by inhibiting vitamin K-dependent factor 2, factor 7, factor 9, and factor 10. Heparin and low molecular heparin act via antithrombin, blocking mainly factor 10A and factor 2A. DOACs are more specific factor 10A inhibitors and factor 2A inhibitor, dabigatran. Next, I will show you some studies for anticoagulation and liver transplantation. These 2 center studies included patients with Yerder grade 1, 2 portal vein thrombosis and compared therapeutic anticoagulation and non-anticoagulation. The result are anticoagulation after liver transplantation did not reduce PVT recurrence. Rates were similar between groups, and graft and patient survival also not different, even in subgroup analysis. So there were no proven benefit of routine anticoagulation in this setting. On the other hand, risks were clear. Bleeding events were much higher with anticoagulation, and more patients needed surgical revision. Several complications, severe complications and longer hospital stays were also significantly increased in therapeutic anticoagulation group. So overall, anticoagulation shows more harm than benefit in this study. Next, this was a recent dual-center RCT, including 462 adult DDLT patients in China. They compared therapeutic dose enoxaparin with saline placebo in the immediate postoperative period. The results show no reduction in venous thrombosis, including PVT and DVT, but significant increasing in major bleeding, 35% versus 26%. So routine prophylactic anticoagulation with enoxaparin after LT did not prevent thrombosis and instead increasing bleeding risk. In the 2 clinical studies I showed earlier, anticoagulation did not reduce PVT, but clearly increased bleeding risk. However, if we look at laboratory markers, the situation is a little different. In the early postoperative day, we see a marker rise thrombin antithrombic complex showing a hypercoagulable status. This explains why clinicians worry about thrombosis early after LT, even though large trials have not shown benefit for routine anticoagulation. So what do most recent guideline recommended? According to the consensus from the Spanish Society of Liver Transplantation and the Spanish Society of Thrombosis and Hemostasis, in patients with risk factor for PVT, therapeutic low molecular weight heparin should be started within the first 24 hours after surgery. For patients who were already on anticoagulation before transplant and are considered high risk, therapy should be resumed within 24 hours after LT using the same drug if possible. So in real practice, Routine anticoagulation after liver transplantation is not recommended. We only consider it in high-risk patients, such as those with pre-transplant PVT, complex portal vein reconstruction, systemic VTE or AFib, or non-hypercoagulable status. Finally, I'd like to briefly introduce 3 additional agents that have been used in liver transplantation: PGE1, antithrombin 3, and napamostat. The PGE1 has 2 main mechanisms: vasodilation and inhibition of platelet. Through this effect, PGE1 is used as a drug to help maintain graft microcirculation after liver transplantation. Next, there have been some older representative studies of continuous PGE1 infusion even outside the LT field. For example, in peripheral arterial disease, PGE1 improved blood flow and walking distance. In hepatic circulation studies, it lowered blood pressure but preserved hepatic blood flow. And CRRT higher dose prolonged filter life and reduced platelet reactivity without systemic platelet dysfunction. This data suggests that PGE1 might improve circulation, which led to interest in its use after liver transplantation. So now, let's move on to the evidence specifically in liver transplantation. This was a randomized controlled trial of PGE1 infusion after liver transplantation. Patients received PGE1 at 0.25 microgram per kg per hour for 4 days post-reperfusion. The results show early allograft dysfunction was lower with PGE1, but not significant. Hepatic artery thrombosis, no difference between groups. Acute kidney injury was significantly reduced, and postoperative ALT level were also lowered with PGE1. So overall, PGE1 did not prevent HAT, but it showed benefit for renal protection and graft injury markers. In the 2023 Cochrane review, prostaglandins may reduce short-term mortality, but no significant difference, while seriously event and graft outcome showed little to no difference. The most consistent finding was a significant reduction in dialysis requiring AKI. So who should get PGE1? In practically, if we were worried about renal function or microcirculatory instability, these are the patients where PGE1 can be a reasonable choice. Next drug is antithrombin 3. Antithrombin 3 is a serine protease inhibitor made in the liver. It inactivates thrombin and factor 10A. Important point is heparin itself has no anticoagulation effect without antithrombin 3. So their therapeutic anticoagulation from heparin simply does not occur. Past studies show that antithrombin 3 level recovery is slow after liver transplantation. This is black circle and dash line. This delayed recovery creates a temporary imbalance and increasing thrombotic risk in the early post-op page. So the clinical implication is rapid normalization of antithrombin 3 after liver transplantation may be important for preventing thrombosis such as HAT and PVT. This randomized trial was conducted here at SNUH. Patients were randomized to receive antithrombin 3 either as intermittent bolus or as a continuous infusion after a loading dose. What they found was that the continuous group reached the target 83 level faster and maintained it more reliably. But in terms of clinical outcome, thrombosis or bleeding event, there was no significant difference, most likely because event rates were lower and the study was underpowered. Evidence showed that continuous infusion achieves faster and more reliable target attainment, but there is still no definite clinical event reduction. So who should we consider? Patient only post-LT page with low 83 level, less than 70%, or when heparin efficacy is needed. And the last medication I will introduction today is napamostat. Napamstat is a short-acting multi-target anticoagulant that simultaneously modulates coagulation, inflammation, iron transport, and endocellular pathway, allowing its use across diverse extracorporeal therapy. In Korean, I might call napamstat the 약방의 감초, meaning it shows up everywhere and can be used in many different settings. The key RCT from SNUH in 2011 showed that napamstat reduced post-reperfusion syndrome and lowered vasopressor requirement in intraoperative phase, but so far, there is no evidence for its use as anticoagulation in liver transplantation. So we mainly consider napamstat use intraoperatively for post-reperfusion syndrome prevention or postoperatively as an anticoagulation during CKRT when bleeding risk is high. It is not used for HAT or PVT prophylaxis. Thank you for staying with me. This long topic is too close. I will summarize the key message in the two next slide. Hepatic artery thrombosis and portal vein thrombosis are the main thrombotic event after liver transplantation. Aspirin has the strong and most consistent evidence for preventing HAT, and it should be the default in liver transplantation. Anticoagulants such as heparin, warfarin, or DOACs are not recommended routinely in average risk patients. They may be considered selectively in high-risk situations. For the other agent, PGE1 provides renal protection and reduces dialysis requiring AKI, but it does not prevent HAT or PVT. And antithrombin 3, continuous infusion reaches target level more reliably, but there is no proven outcome benefit. Napamstat showed to reduce post-reperfusion syndrome and vasopressor use intraoperatively and useful in CKRT when bleeding risk is high, but it is not recommended for routine HAT or PVT prophylaxis. Thank you for attention.